lastly in this discussion, just, and we will get to some of the options second line, but cytotoxic options for a patient who has progressed either on an induction regimen followed by maintenance or just an induction regimen, options on the table. Can we give these patients who have received carbo-nab-paclitaxel another taxane? I mean, I think there's a data that there is response rates with retreatment of a different taxane. Are we moving more towards gemcitabine, navalbine? We're going to table the checkpoint inhibitors for now, but other options for these patients?
Well, they're certainly more limited, I think, than lung adenocarcinoma, which is the frustrating thing. And in terms of cytotoxic, we again are limited by what we gave in the first line setting. So for someone who's gotten a taxane doublet in the first line setting, we're left with gemcitabine by itself, some data for gemcitabine, vinorelbine some people give, vinorelbine by itself some people give. So it's sort of what's left, and then you give it depending on the side effect profile and exactly what the patient looks like. But outside of that, there's not a lot. Platinum, taxane rechallenge can work, certainly for a study that we're going to talk about a little bit. On a subset analysis for ramucirumab, there was still a trend towards benefit for patients who had already gotten a taxane before. So certainly these are the options. They're not very good options, which is why, as Ed had said, approval of the first immune checkpoint inhibitor was met with such welcome and applause, I think, from the community.
Okay, Ed.
Yeah, I think it's something that an oncologist or a provider team dreads. It's almost like back to the third line discussion of non-squamous, where okay, you got vinorelbine, gemcitabine, irinotecan, any of the TKIs, and the data is very scant. It's very loose. We hate that, especially as we brought up the pies earlier, and you can subset people. I do think the fact, and you brought this up earlier, that steroids are not required with nab-paclitaxel. That will be a favorable regimen used up front unless some data just clearly changes that with a doublet, because immunotherapies will become so valuable that they don't want to do anything to try and compromise that. I don't have any problem using a docetaxel with ramucirumab in those patients who can tolerate it. Erlotinib is certainly an option. After that, it gets really dwindly as far as data. Single agent gem is there, but where's vinorelbine anymore? Do we even use that drug anymore? I mean, it's got more approvals than a lot of drugs now.
Yeah, I think our options are a little bit restricted in this patient population. As you said, I think immunotherapy has completely changed the game, where we're having this conversation about chemotherapy options as third line. I, like you, am not afraid to use dosi-ram in a second line setting for a patient who may not be an immunotherapy candidate, or even single agent gemcitabine. I have not used a lot of navalbine in a long time, which I guess is a good thing. I think that the more we can talk about not using chemotherapy and using other alternative strategies that are creative like immunotherapy,